Well, I want to welcome you today to a very special edition of CMDA Matters, our weekly podcast. And this week, because of a topic that we want to bring to you in a special edition, we decided to have an interview, myself with Dr. Jeff Barrows, who's our Senior Vice President of Bioethics and Public Policy. I'm Dr. Mike Chupp, the Chief Executive Officer of CMDA. And we decided, after receiving a number of requests, Jeff, from our members to speak out on the issue of vaccination hesitancy. A number of articles were sent to us. One in particular that came last week was an article from the Washington Post that the religious right were really pushing back against getting vaccinated because of all kinds of information that's out there and a fair amount of misinformation. I'm sure that you've been asked lots of questions by family and friends.
I've had members write me and say, will you look at this video and tell me how accurate it is? And of course, looking it over, there's all kinds of misinformation that's on there. And I'm amazed that a lot of it is being put out by physicians and others in front of large churches, which is unfortunate. So I think it's important for us to try and address these things.
Well, there was a line toward the end of that article in the Washington Post that really stood out to me as a leader of a fairly large Christian healthcare organization, membership of 20,000 members, that it should be those who are on the inside of the church, within evangelical Christian organizations. Some surveys I've read recently, actually evangelicals are on the higher end. I know that the African American population has been suspicious, but so are white evangelicals. Higher numbers than the average population of saying, we're not going to get vaccinated. And I have to say, it's not too hard for me to believe because I've had family members, Facebook, hey, we're not going to be vaccinated. So we decided to come together and just wanted to have a brief talk, asking you some questions, Jeff. You have taken it upon yourself for the last 6 or 8 months to kind of keep your finger on the pulse of the development of the vaccines. The two of us had a podcast, an interview with Tara Sander Lee, with the Charlotte Lozier Institute, talking about the ethics of some of these vaccines, and that's been a big focus of yours. But now the vaccines are available, and CMDA, our mission is to educate, encourage, and equip you as a Christian healthcare professional, or if you're not a Christian healthcare professional, your physician, or those in your family who are healthcare professionals, to glorify God. And so we felt that at this point in time, with 2 vaccines, and I'm told the third one is maybe February 26th going to...
later this week. They're going to go before the FDA and try and get their emergency use authorization as well.
Well, let's jump into these questions. Many people, of course, are concerned because of this mRNA, messenger RNA technology that's been developed, and there's a lot of touting of that technology, and of course the warp speed pushing through. So could you address people's concerns about this new technology?
Well, Mike, I think it is a little unfortunate that the technology behind these first 2 vaccines is relatively new. I will say relatively new because it's not brand new. It's actually been around for about 5 to 6 years or even longer. The ability to manufacture or in the laboratory, messenger RNA has probably been around for many, many years, but it's been a technology kind of looking for a way to be used medically. And so there was thought of using it as treatment, for instance, in various medical diseases. But it wasn't until about 6 years ago that the researchers settled on the idea that the technology would be great for the development of vaccines. And so one of the lies that's out there is that these have never been tested before. It's brand new technology, and that really is not true. Actually, Moderna and some of the others had used this technology in terms of a vaccine and actually started phase 1 trials with rabies, with a vaccine against a couple of influenza viruses, with cytomegalovirus, and then most recently in 2019 against the Zika virus. And all of these were phase 1 studies with humans.
In the last 4 or 5 years.
In the last 4 or 5 years. And in fact, they were getting ready to do phase 2 studies with the Zika virus, and then this thing came along called COVID-19. And they realized quite quickly that it was very important to shift gears and move on and try and get something developed for COVID-19. So even though it's relatively new, it's not brand new, it's been out there, it's had animal studies as well as phase 1 human studies.
So how would you address the concerns, and these are the concerns that have come to me, these videos of physicians, specifically physicians from various organizations, you and I, the two of us have talked about this, what is the motivation here? Tough to know what the motivation is, but the physicians putting out information that using the word experimental over and over and over again, and therefore safety has to be called into question. How would you respond in terms of the safety of these vaccines right now as they're being given?
Yeah, I would start with the fact that we've had phase 1 studies with 4 different vaccines using messenger RNA technology. And then when Operation Warp Speed was set up, even though the name was probably not the best name to choose for it, there were criteria that were set up for these companies that they had to follow in order to get the funding from the federal government. And a major part of that criteria was when they moved into phase 3 studies, they were required to enroll at least 30,000 volunteers in the phase 3 trial, 15,000 in getting the vaccination itself and 15,000 getting the placebo. And so Moderna enrolled about 30,000. Pfizer went ahead and enrolled about 44,000 individuals, about half getting, again, the vaccine and half getting the placebo. And after all of that was published, they also had to wait a full 2 months after the second dose was given to see if there were any short-term reactions to the vaccine, such as things like Guillain-Barré syndrome or others. And once that time had elapsed, they then went before the FDA with all of their data, including the animal studies, all the human studies from phase 1, phase 2, and phase 3, went through the process with the FDA with all of that science, and then they were granted an emergency use authorization, an EUA it's called. And since that time, of course, we have vaccinated well over 60 million people. And the CDC just not long ago released their report of the first month of experience, which was covering about 13.8 million individuals that got vaccinated. And they found that, again, it's going quite well. The most common types of reactions are local reactions, a little bit of fevers, chills maybe, which is part of our immune response to the vaccine itself. And there were about 9% that they called serious complications, but we have to remember that about 1 million of those doses were given to individuals who were in long-term care facilities. Mm-hmm. And of course they were at the end of their life, having multiple illnesses and morbidities, and so they looked at whether the incidence of those serious events would be greater than what they would expect with that population, and they did not feel that it was. So with that, I think we can feel very comfortable that it's really very safe, as safe as we can say.
Well, as you mentioned, I mean, the name brought a little bit of concern, but in terms of the phase 1, phase 2, and phase 3 trials, was anything changed from behaviors that have been done in the past with trials of vaccines? Certainly the time has been compressed, and the federal government did some things to help these companies, Pfizer and Moderna, to be able to ramp up their production before approval. But in terms of the FDA's involvement, external observers who've looked in, any reason to think that anything has been different about the phase 1, phase 2, or phase 3 trials?
No, they were just kind of overlapping each other a little bit more than usual. And again, the average phase 3 trial before COVID-19 would enroll 4 or 5, maybe 6,000 people, and then they'd look at the data, and they take a lot longer time in evaluating and enrolling. And so because of the nature of the pandemic, the CDC and the FDA recommended to the government to say, let's try and get 30,000 all at once so that we can move it a little
larger
quicker.
Numbers in a shorter period of time.
Exactly.
In a way.
Exactly.
Different question. There are some physicians, some healthcare professionals out there who are saying that there are some medications, now realizing that this has been unfortunately politicized over the last year, but there are some medications available, for example, hydroxychloroquine, ivermectin, that are available, and because of those, for mild, moderate cases of COVID-19, vaccine is unnecessary. How would you respond to that?
Well, I think it really goes to the science. And I know I practiced at a period of time when we began looking, for instance, as an OBGYN, at hormone replacement therapy. And the initial results and tests that came out were retrospective studies. They were case studies as well. They weren't the best gold standard of medicine that we all have learned to respect, and that is the randomized, prospective, especially if they're double-blinded or blinded studies. And so the initial studies that showed that hydroxychloroquine, for instance, had benefit were all retrospective studies, or they didn't have a lot of individuals enrolled. You really have to have 500 to 600 individuals to have really enough to really look at the statistics properly. So when you begin to narrow down the studies and say, well, what do the randomized prospective studies that have many hundreds of individuals show, unfortunately, the benefit begins to disappear. There was a report in November that was published in the New England Journal of Medicine. It was studies that were done at 55 centers in Brazil. They had over 600 individuals. They had mild to moderate COVID. They had been hospitalized. I think they were probably hospitalized because it was a different way to treat the people in Brazil. But they actually put it in 3 different groups. They put it in the standard care group where they could get oxygen or corticosteroids or whatever the doctor felt they needed. That was the control group. Then they added hydroxychloroquine to another group, and then they added hydroxychloroquine and azithromycin to a third group. And the bottom line from the study was that the hydroxychloroquine alone or in combination with azithromycin did not help the patients with mild or moderate COVID-19. And so when you see a study like that that's prospective, well done, with a lot of numbers, you got to go, is there something going on? And then just to let the viewers know that I looked recently at the Cochrane Review database, and just this last week there's been a Cochrane Review that's been published, and again, that's looking at all the studies, at the way the studies are done, at whether there's bias in the study, the numbers and that type of thing. And basically, without going into a lot of detail, the conclusion of the researchers was that hydroxychloroquine does not help, and in fact, it does tend to cause an increase in adverse events. Nothing life-threatening, but certainly the prolonged QRS interval that we all know about. And finally, I was a little surprised. They actually recommended that we do no further studies with hydroxychloroquine because it has not shown its benefit.
What about any other medications? I mentioned ivermectin, or any others on the list that have shown promise?
Ivermectin, it's too early to say. The official stance of the National Institute of Health right now is that there are too few good quality studies that show benefit or lack of benefit. So it really needs to be studied still, and I'm waiting for a good prospective randomized study to give us the answer to that question.
Well, I didn't talk at all about your credentials when we first got started, Jeff, but you have a master's in bioethics from the Center for Bioethics and Human Dignity at Trinity International University. And I'm going to throw you now a little bit of a softball, because this is the area now in terms of the ethical vaccines. And you've done some writing with our Director for Government Relations, Jonathan Embody, in the blog called Public Discourse on the ethics of these vaccines. And we get a lot of questions, a lot of stuff on our website, cmda.org/coronavirus, and some tables that you've put together on the various vaccines and their relationship to development with these cell lines, fetal-derived cell lines, that came from abortions that happened decades ago.
Right.
So would you update us, for our listeners, those who are watching or listening today, where things stand in terms of the ethics of these vaccines, and is this something that should cause people to pause before getting vaccinated or not?
Yeah, that's a great question, and we get asked it a lot by members and even those outside the membership that are not part of the medical profession. And I didn't really understand the connection between abortion-derived fetal cell lines and vaccines until I really got into this position and began researching it more. But there are several vaccines out there right now. Even rubella uses abortion-derived fetal cell lines. And so it is an ethical question. But what we have found is that there is a different level of association between the different vaccines. And there are really 3 possibilities or 3 stages of the vaccine development that can be used: in the design stage, in a confirmation stage, or the worst for us in terms of being ethically problematic is at the ongoing production stage. So for the 2 vaccines that have received an EUA from the FDA, both the Moderna and the Pfizer vaccine, both of those use these abortion-derived fetal cell lines in a single confirmatory step just to make sure that the mRNA they were manufacturing truly produced the spike protein that it was supposed to. Now, Johnson & Johnson, as you mentioned, is coming up before the FDA later this week. And their vaccine is different because they have a different vaccine platform. Theirs is a viral vectored vaccine, and it will take genomic material into the human cells using an adenovirus. And the difference is that Johnson & Johnson, as well as the AstraZeneca vaccine, grow that virus on these abortion-derived fetal cell lines. But I would say that us at CMDA, even if your only choice is a Johnson & Johnson vaccine, we would still recommend getting it. And let me give an imaginary scenario that may help those who are listening or watching kind of understand why we would say that. Because again, the abortion was decades ago. So I would just ask you to imagine that you're in an emergency room, you're staffing that emergency room, and a 6-month-old baby is brought in by her mother. And you find that the baby has been beaten horrifically by a stepfather. And in fact, the baby is badly brain damaged and is going to die. But you also know that upstairs in your hospital, you have a 6-month-old baby that was born with a severe cardiac anomaly. Are you going to have an ethical problem with taking the heart from that brain-damaged, about-to-die baby and giving it to the baby that has the congenital heart defect? I know I personally wouldn't have a problem with that. I don't think most ethicists would have a problem with that. And in essence, that's exactly what's happened with the abortion-derived fetal cell lines. As far as we can tell, there is absolutely no connection between the abortion and what happened with getting the fetal cell lines later. It's just somebody said, hey, since you've already done this abortion, I'm going to try and develop this cell line from the cells that you've taken out of the mother. And of course, the abortion is clearly evil, just like the abuse of that baby is evil. But the good that can be derived, we think, far outweighs any association with evil.
Certainly a huge gap of time.
Exactly.
There. Well, we've heard about, at least I've heard about microchip questions and nanobots and changing our DNA. There's some other controversies that people have used to maybe push back and say, I'm not going there.
Yeah, there are a lot of crazy things out there. I'm amazed at how people come up with these crazy things. The one that would make a little bit of initial sense early on would be, okay, we got something that's kind of related to DNA, so does it have the capacity to change our DNA? Well, if you go back to physiology and you recognize how mRNA works, you know that it actually never goes into the nucleus of the cell. So all of our DNA in every cell in our body is contained in the nucleus. When the cell takes in this mRNA from either the Moderna or the Pfizer vaccine, the mRNA never goes to the nucleus. It goes to the ribosomes, where it begins coding for the production of the spike protein. And so we don't have any concern. It can't change the DNA because it never gets near the DNA. The other thing that I've heard out there that's somewhat related is that it goes to every cell in your body. And again, this is where another of the animal studies is very helpful. They've actually analyzed within mice the COVID-19 vaccine, the mRNA vaccine, and how is it distributed through the body. And as we would imagine, it's highly concentrated where we get the injection in the deltoid muscle. It then goes into the lymphatics and then quickly it dissipates throughout the rest of the body because we have all kinds of enzymes that destroy mRNA if it's in the bloodstream freely. So we don't have to worry about that. In terms of the tracking, what I would simply say, and I've said to many people, is the government doesn't need to invest in that. All they got to do is track our cell phones. They can track us wherever we go just by our cell phones. Anybody that carries their cell phone with you. Now, is the government tracking us? I don't know. I haven't looked at that question, but they don't need to spend any time or money developing any kind of microchip that they put into a vaccine. They already have the technology to do it.
Well, it certainly doesn't appear that anything's being placed on foreheads or on hands in this whole
Not
process.
that I've seen. I think some people have come up with a 060606 number with some kind of weird, strange patent, but it doesn't concern me.
The one question that even my own wife has asked me, and I have to say, of course, we can't answer this question, but are the long-term impact of these vaccines. And so I think a question I asked you earlier this week, do we have any evidence from past vaccines that there could be long-term effects from a vaccine, recognizing that we don't have any mRNA vaccine that has a long track record? So how would you respond to that concern?
At first look, it is a valid concern because you're right. We do not have long-term. What's the longest term? Probably the phase 1 participants probably got the vaccines maybe 9 months ago, maybe close to 10 months ago. That was a few hundred individuals. And it's going to be several years before we can really know a good answer to that question. But when you look at the history of vaccines and you look at, for instance, back all the way to polio vaccines, and you say, what were the problems that occurred? It's interesting, there was a problem, but it was in the manufacture of the vaccine. And in fact, there was a company that was supposed to be making killed polio virus vaccine, and they didn't successfully kill the polio virus. So then when they administered it to people, people caught polio, but that's a manufacturing problem. There has been a little bit of association. I briefly mentioned the Guillain-Barré syndrome. I vividly remember in medical school, I was on my clinical rotation in an ICU, and I remember somebody on a ventilator because of Guillain-Barré because they got a vaccination. And so there was a little question with association between some of the vaccines. I think that may have been an influenza vaccine. And there has been a little bit of an association with that. Several other vaccines since where the question has been raised, it's really been disproven. There's only been one vaccine that I could find that's been taken off the market because of long-term consequences, and that was a vaccine against rotavirus. And it was given in kids because they were getting real bad diarrhea, given across the world. And unfortunately, it appeared that this vaccine caused intussusception in infants that were less than 12 months of age. And so when the company realized that and it came out and it was studies, they took it off the market. But other than that, almost every vaccine that we've had approved in the United States is still around.
Well, as we wrap up this interview, I'd like to ask you to help our viewers or listeners. There's tracking websites where you can go and track all sorts of information about this pandemic, cases, deaths, and so forth. What sites or source of information would you suggest people can go to that they can track and follow the data on how many people have been vaccinated? Is there a data source for how many people are having anaphylactic reactions or any other sequelae from getting vaccinated?
Yeah, that's a great question. My favorite is the CDC COVID tracker. And they have kind of a complicated webpage, so I can't give that easily. But if you just Google CDC COVID-19 tracker, it'll come up first page. And it's an excellent page. It'll tell you the number of infections, the number of cases, the number of deaths, the number of vaccinations. It'll even give you a map of where the vaccinations have been given. And in terms of long complications, the CDC has what they call the Vaccine Adverse Events Reporting System, VAERS. And you can, again, Google that, CDC VAERS, and you can get a web page that gives you a lot of information about that. But they have actually an online tool called the VAERS Wonder Tool. And if you're really good at computers and numbers and Excel and sheets, you can actually go in there and look for any kind of complication you want. It's up to date within like a day or two. I started looking into it the other day. I was a little overwhelmed with how it worked. I realized it was going to take me several hours to figure it out. But the data is out there for those that are inclined and have the ability to do that because it's kept up to date. And I've been fortunate to get 2 Moderna vaccines. I just got my second one last week. And when you get your vaccine, you're automatically signed up to be part of the VAERS system. So I've been getting a daily text to kind of check in, and they ask you various questions. How are you feeling? Do you have any tenderness? Were you not able to work? And you're putting those into the cell phone, and then it goes back to the CDC, and that's how they're keeping track of these adverse events.
Is this a first for CDC to do this level of monitoring?
Well, with the app, it's the first because of 19. I think that they were doing it before, but never this closely and person by person with the app.
Thank you, Dr. Barrows, for all the hard work that you've done monitoring all this, for sharing all this information, preparing to share with us today. And I just want our listeners to know, if you want to know what our official position statements are about vaccines, you'll find them online on our website. Drop down for our position statements about vaccines. And in general, CMDA has historically been very, very pro-vaccine, with the push to vaccine manufacturers to do whatever they can to avoid these any ethically pure vaccines, I've heard you say.
Right.
So we avoid those in the process. And I can tell you that our board of trustees, we met in January. Those who got vaccinated gathered together. We did physical distancing. It was half of our board of 21 or 22 members. And I can tell you we're going to meet again at the end of April before the national convention. And I know that every board member is trying to get vaccinated, including our president, so that they can gather together. So it's not as if we're 50-50, even on our board of trustees. All of our board are trying to get vaccinated. And so we want to challenge you, whether you're a healthcare professional or not, to keep following the evidence, the trackers that Dr. Barrows has talked about, because we want to be a part of the solution in the Church of Jesus Christ, bring glory to Him, not part of the problem in delaying this pandemic.
As Christian healthcare professionals, our Lord Jesus reminded us to love your neighbor as you love yourselves. And so many of us recited the original Hippocratic Oath to, above all else, do no harm. Unfortunately, the church can cause harm unintentionally, simply by being misinformed or uninformed. There's a book by Dr. John Kilner from the Trinity International University Center for Bioethics and Human Dignity entitled Why the Church Needs Bioethics, a Guide to Wise Engagement with Life's Challenges. Now, this book equips students, church and lay leaders, and people in health-related fields to understand and constructively engage bioethical challenges with the resources of Christian wisdom and ministry, so that we may be a voice in the wilderness that is secular culture today. Well, for our lay listeners, or maybe spouses of listeners, the healthcare system and processes can be overwhelming and confusing. The book, Lost and Found, A Consumer's Guide to Healthcare by Dr. Peter Anderson and Dr. Paul Grundy, it helps break down the issue in terms that everyone can understand. It's a great resource to have in your waiting rooms or to recommend to your patients. You can get a copy of one or both of these books at cmda.org/store or just by calling 888-230-2637 today. I want to invite you to join us for fellowship, encouragement, and spiritual renewal at the CMDA Virtual National Convention under the theme, Courage Through the Crisis, Stories from the Front Lines. This event will include lectures by notable speakers as well as breakout sessions during which you will have the opportunity to fellowship with like-minded healthcare professionals. Some of our speakers in this event will include Reverend Al Mohler, president of Southern Baptist Theological Seminary, best-selling author Philip Yancey, pro-life activist Dr. Alveda King, who's the niece of Dr. Martin Luther King Jr., and Reverend author Bert Jones will be our Bible teacher. And just informed this week that our live musician who'll lead us in worship music will be returning artist Mr. Ryan Kennedy. It'll be live from our CMDA national headquarters. You can find out more information and register for these events at cmda.org/events, or you can find links in our show notes today online. You know, this past weekend, CMDA hosted a webinar entitled Clinical Perspectives on the Transgender Movement, with two excellent presentations by pediatric endocrinologist Dr. Paul Roos of St. Louis University, and that was followed by excellent question and answer sessions. We had over 1,000 people who registered, and nearly 500 people attended the live presentation. Dr. Ruse discussed what we know about the management of gender dysphoria, including transitioning children and adolescents with puberty blockers, but he also discussed what we do not know. You know, if you missed our webinar, you can still access it by going to cmda.org/learning, and that will take you to our CMDA Learning Center. And my staff tell me that they have now made it so that you can get over 2 hours of Category 1 CME by going to the Learning Center and watching these videos, whether for the first time or a repeat, going back. And if you'll remember the promo code Transgender Truth, one word. This is a free course, even if you're not a CMDA member. We're doing this one time only. You know, this was part 2 in a series on the transgender movement, with the first webinar last October on theological perspectives on transgenderism by Reverend Andrew Walker. You can see his presentation at the link I just mentioned as well. I believe that what we learned from Dr. Ruse on Saturday is that this movement is being fueled entirely by ideology, and with it a distorted treatment of clinical studies that have been done, studies which make conclusions that the data contained within cannot substantiate. Well, as I close, I want to make sure that you tune in next week for a bit of a lighter episode. Dr. Autumn Dawn Galbraith, one of our women physician in Christ leaders, and Philip Yancey will join me to discuss how God has redeemed this pandemic for his own purposes. You won't want to miss it. As Christian healthcare professionals, we at CMDA know that providing your patients with sound medical advice, with recommendations that are based upon a rigorous and transparent critique of the evidence, matters to you. Yet in a culture wrought with misinformation, it can be difficult to know who to trust these days. Providing you, our members and our listeners, with credible information matters to us at CMDA, and CMDA matters. Thanks for listening today. We'll see you next week, God willing.
This podcast has been a production of the Christian Medical and Dental Associations. The opinions expressed by guests on this podcast are not necessarily endorsed by the Christian Medical and Dental Associations. CMDA is a nonpartisan organization that does not endorse political parties or candidates for public office. The views expressed on this podcast reflect judgments regarding principles and values held by CMDA and its members, and are not intended to imply endorsement of any political party or candidate.